Okay, good morning, everyone. My name is Rui Duarte. I'm a neuroradiologist in Lisbon. And first of all, let me thank you all for being here. It's amazing to see all your faces after what was an amazing experience as part of the organizing committee for this meeting. We called it for a while, as Esther was saying, the Rui edition, because there's me and there's the other Rui. But I think it's in fact Rui's edition, as in Rui Simões edition. It was great as the true one and only local host here in Porto. And it's also his birthday today. So if you find him in the coffee break, yeah, or just clap, I don't know. But we have to thank him a lot for putting this in place. And I'll be talking a little bit about state-of-the-art glioma imaging, so the present of glioma imaging in a clinical sense more than anything else. This is a summary of the presentation, just a list of the MR techniques I'll be going through over the next few minutes. Also a photo of my new institution in Lisbon, which is quite close to the river Tagus in the sunny city of Lisbon. So if it starts raining here, and below it is the Stanford Healthcare Hospital in Palo Alto, California, where here. It's also where I've met Moss Zhao, who is one of the original members of GliMR, and he kind of introduced me to the group. So one of the reasons for being here today. So thanks, Moss, also for that. In terms of introduction, I knew the previous talk would let us know everything about all the imaging techniques that helped us before MR started. So I just wanted to give some clinical perspective into the problem we are dealing with here. Central nervous system, so 3.5 per 100,000 in population. But this is highly dependent on country income. So if you look just at high income countries, it's 7.4. And if we look specifically into the United States, where they have fancy hospitals like the one I've just shown, it's 24.7. Interestingly and alarmingly, it disproportionately contributes to mortality and morbidity. So, for example, in young men between 20 and 40, it's the second leading cause of cancer-related mortality. And this happens not only because we have a lot of aggressive tumors in the brain, but also because our treatments are sometimes not very good for the patients. So we have to think well about these numbers and maybe all these undiagnosed tumors that in other countries are never cause a problem. So when we are deciding to treat these patients, we have to think where we are. We have to think about access to healthcare and especially about access to the crown jewel of our day-to-day in neuroradiology, which is MRI, of course. Another way of putting things into perspective is to look at these very old graphs from one of the classic books of neuroradiology, Osborne's Brain. The first one is distribution of prevalence for all intracranial tumors, and we can see it's more or less evenly distributed between metastases and primary intracranial CNS neoplasms. And the second one is basically just looking closer at the right half of the first one. And we can see that gliomas are actually less than a fourth of all intracranial primary CNS neoplasms. But this must be really important. If it's just a small piece of the pie and all of us are working and doing research on it, it must be important. Doctors also like to start looking at diseases by classifying them. So it's a good slide to put in an introduction. And as was said already, the classification of central nervous system tumors has been through some changes lately. More importantly, with the 2021 WHO classification, that is really swinging things towards genetic and molecular classification, which makes it quite difficult for us in radiology in general. This is a summary, a nice summary, but it's 20 pages long. And if we are a radiologist that's really interested in staying updated, we should also read this Impact Now publications by a consortium specifically looking at the molecular classification approaches that we should take into account with CNS tumors. This one was released in 2016, but then we have to read the update number 1, of course, update number 2, 3, 4, 5, 6, 7, and yeah, all of a sudden we are bracing for impact. It's a really complex subject. This is another nice summary with a table, so it should be good. And in the red part, I've highlighted only the gliomas. But we can see that there are a lot of entities here, and it's easy to imagine why with basic T1 and T2 imaging, it would be difficult to distinguish between all of these. So there must be something else. There must be advanced imaging that can help us. And also, maybe we should try to think back to the goals of our job as neuroradiologists, and instead of that beautiful romantic notion of the surgeon coming into our dark underground room and asking what tumor it is, and we say the right diagnosis and he lives forever happily. That's probably not true, and probably it has never been true. But we should focus on questions that we can really give good answers to and help the patient with. Starting with the most basic, the differential diagnosis, we should be able to say if it is a tumor or a mimic. This is not always easy, and most of us have made mistakes in relation to that. I've also heard some neurosurgeons saying we've all biopsied an MS case, for example. So there are difficult things that can look like tumors, and the first thing we should be able to say if it's a tumor or not. If we really establish it's a tumor, but still inside this differential diagnosis challenge, we should try to see which type of tumor it is. Is it a glioma, for example, in this case or not? And if possible, give some hints on the grading of it. Biopsy guiding is really important because doing a brain biopsy is not easy, of course. It also has some morbidity associated with it. And there are definitely some things we can see in imaging that can help the surgeon decide where to put the needle on. And he should be asking us for help with that too. And if we decide that surgery is the way, we have some nice tools for preoperative planning. fMRI and DTI at least have been shown to be effective in preventing neurological damage after surgery. So it should be done and added to our imaging checklist before surgery. And of course, imaging follow-up, a lot of publications also coming regarding that, and the differences between a possible tumor recurrence that is highly probable in high-grade gliomas and mere treatment effects of surgery or of radiotherapy mostly. And as we go into the techniques themselves, and as I was starting to prepare this deeply, and thinking about also the theme of the meeting, which is GliMR, past, present, and future, I was lucky enough to have this very present output from the group in this two-part series of articles about specifically the advanced techniques that we can use for preoperative glioma characterization. And from now on, I'll pay some sort of homage to this article and try to follow its structure, at least in terms of the order in which I'll present the techniques. So I'll start, as the article starts, with EST perfusion, the more established version of MR perfusion. We can call it susceptibility-based perfusion or T2 star perfusion. It allows us to generate relative CBV maps that reflect the vascular endothelial proliferation, vascular density, and neoangiogenesis in the tumors. So these are frequent markers of a high-grade tumor, but not only. It has been suggested as a possible technique in grading prediction, risk stratification, to help, as I was saying, guiding the biopsy to avoid those shoots for the biopsy, and give us some hints at possible molecular subtypes also. But it has pitfalls, of course. There's an we can see that post-operatively is not the best technique, probably. Alter the way our map is showing the CBV of the tumor itself. And I couldn't talk about DSC without mentioning FDB, fractional tumor burden, which was developed by Michael Eve's group at Stanford. He was kind enough to give us a short presentation last year in Turkey. But for those who weren't there, this is it seems like a very basic alternative to manual ROI placement and looking for relative CBVs inside the tumor. It's basically just a three-step approach. First, the software automatically generates a delta T1 map, which is just a co-registered map showing us the actual enhancing area in the tumor. Then for that volume of interest, we are going to divide it according to predefined CBV thresholds, 3 thresholds. In blue, coded in blue, it will be the low fractional tumor burdens, where our CBV is less than 1. In yellow, mid-fractional high fractional tumor burden with RCBVs over 1.75. And this correlates very well, especially low fractional tumor burden with treatment effects and high fractional tumor burden with tumor recurrence. Finally, we generate these maps and histograms that show us for that volume what's the percentage of these 3 different areas. Some examples, we have an enhancing lesion in the FTB map that it's mostly blue, so this is highly, with high probability, just a treatment effect. And this one on the T1 post-contrast would look probably more or less the same, just an enhancing area after treatment. But we see in the FTB map that it's mostly red with some yellow areas around it. So we can, with a high degree of confidence, say this is probably tumor recurrence. On to the next perfusion technique, which is DCE or T1 perfusion. Here, the signal records information about blood perfusion also, but the keyword is vessel permeability. So we are evaluating the ability of those vessels to retain blood, which is sometimes compromised in these neo vessels that are produced by the tumor itself. The clinical applications are more or less the same, but with an important addition of this differential diagnosis against lymphoma, which is interesting. We'll see some images afterwards. In terms of pitfalls, there's still a higher variability between scanner sequences and software associated, and with DSC, it's not as well established. And also, it's more time consuming in general. So in a real world clinical scenario, we know that time is always something we have to take into account also. So this has probably hampered the development of DC further. Here is that example I was telling you about. So GBM versus lymphoma. And even though in the traditional DSC perfusion, we see that GBM has higher perfusion metrics than lymphoma. In terms of K-trans permeability, the lymphoma is much higher. So it's not always a case of just having a technique that tells you this is high grade or low grade, this is more or less aggressive. We have to play with all the pieces of the puzzle to try to reach final understanding. The last MR perfusion technique I'll be talking about, and probably my favorite of the 3, is ASL, or labeled blood perfusion. Here we don't need an exogenous contrast agent, so we are using our own blood, labeled blood in the neck, to establish and to be able to quantify how much volume of blood is being delivered to each voxel of the brain. Also important in the differential diagnosis, it has been shown to be able to have some a word to say on grading prediction also. Especially important in situations where we're trying to avoid injecting gadolinium, either because the renal function is not great, or it's a pediatric patient that you want to do the MR awake and you don't want to get an IV access just before the procedure if you want them to lie still for 40 minutes. So these are very practical considerations where ASL can be very important. We have to take into account that the signal to noise is usually lower than traditional DSC. And there's still some lack of expertise in reading these images, even though I think, I might be biased, but I think it's changing. This is a very simple scheme where we are labeling the blood in the neck and then subtracting the labeled and non-labeled images to generate a CBF map. And this is from the GliMR article itself, showing us one of the advantages against DSC, because these areas of dropout inside the tumor in the necrotic are probably some blood product areas do not exist in ASL because it's not a T2 star based imaging method. In terms of diffusion or water molecule motion quantification, we've seen that low ADC or restricted diffusion usually comes up when there's high cellularity, so the cells are very densely packed and the water is not able to diffuse freely. It's also in the DTI version of diffusion imaging important to see that we have anisotropy changes in the white matter when there's infiltration or fiber disruption by the tumors, especially in high-grade gliomas. This can be important for, again, differential diagnosis, not only against lymphoma, which is classical, but other tumor mimics like subacute infarcts or abscesses. Diffusion is always a good way to start looking at it. It has pitfalls like all the others, so multi-directional DTI can add significant time to the study also. And we have this perfusion effect that can influence the ADC readings in highly vascular tumors. This is one of those cases where a pitfall can then become a new technique. So the perfusion effects measured in DWI imaging are now a way to measure perfusion with a diffusion sequence. And I think I've organized the slides this way also to make us think about that. Sometimes a pitfall or an artifact is used, and it has been done in the history of imaging for a lot of times. It can be used to develop a new technique, a new way of looking at it. And it's also a good reason to start researching about the new technique. So reviewers will like it and funders will like it. If you have a reason to stop using one technique and start researching about the other, you'll probably be good to go. SWI, or qualitative evaluation of susceptibility differences, is important because different tumors have calcifications or not, are prone to hemorrhage or not, have more or less neovascularization, and so SWI can help us with that. Alone, I've put this in italics because I don't think it's great at grading prediction or hinting at molecular subtypes. Some works have been published on it, but I think mostly in conjunction with other techniques. It's also difficult to interpret in the postoperative setting where there's again a lot of blood involved. But I like this image from Professor Turner's chapter of the SNR book, where she's trying to distinguish between pyogenic abscess, fungal abscess, the demyelinating lesion, and the GBM. With all these techniques, and SWI is here also, and we can see that the wall of the tumor is quite different from the capsule of an abscess, for example. Spectroscopy or brain metabolite mapping is another difficult subject. We know that high membrane turnover and axonal loss in tumors will, in theory and in clinical practice, produce different spectra in the neoplastic tissue. This has been around for quite a while already. We have this very important hint at molecular subtype with a metabolite specifically appearing in IDH mutant gliomas. But it's difficult because we really need experts around us in a clinical setting, which is not always easy. It's much more dependent on acquisition and signal processing methods than other, or probably all the ones I've mentioned before. So even though these beautiful images, we can all recognize the elevated peaks, and we've seen it in books for some years now. It's still difficult to determine if it's part of the past, present, or future of glioma imaging. Luckily, we have some great experts at GliMR also. So if you find Gilbert, I'm sure he'll be happy to tell you all about his work on MRS and to prove that it's all of those probably. MR-PET is a complex system that is able to combine the high resolution anatomical imaging we are used to in MR with the information given by injecting radioactive tracers that can be modeled as we wish to try to understand the molecular processes in the lesion we are studying. So it can be very important when available, of course. Especially in the post-treatment setting, it's an easy way normally to help us to decide if it's tumor recurrence or a treatment effect. But it's a very expensive system. There are not many worldwide, even in high-income places. And there's also limited access, of course, to the cyclotrons producing the tracers we will be in AI generation of fake PET images, basically taking into account some basic MR sequences. We managed to produce fake PET images that are not that different from the original. Here is an example. So this is what we've fed the model with: T1 post-contrast, flare, and ASL. This is the acquired PET for this lesion, and this is the synthesized PET. We've done some reader studies, and I can tell you, not much because it's under peer review, but 87% was the overall accuracy for all readers using the synthesized PET. So this is just to show that maybe AI will bring to a broader audience some techniques that previously would be impossible to get in smaller institutions or smaller countries. So never dismiss something as something you don't need to study, because in a while it will probably be there, and you'll have to know how to interpret it. Others that I've left behind, I've left for the presentation on the future of glioma, vessel wall imaging, MR fingerprinting, CEST, and radiomics. I think these are still more future than present. Hopefully somewhere between today and the day where there's no more life on Earth. That would be useful, but we have to stay tuned. Just some words on fMRI also, because it's not mentioned in the article, but I think it's quite important for preoperative planning. We know how it's done based on the changes to hemoglobin. When brain area is active, there's an overcompensation in terms of CBF. We accumulate deoxyhemoglobin that increases the T2 star signal that can be measured, and we can then produce statistical maps showing us which areas are being activated traditionally in a task-based MRI through a series of cognitive stimuli or prompts that are asking the patient to perform some tasks he's been trained to do. We then get this this is a real life image where we have our tumor and some important language areas right beside it, and in a clearly left side dominant patient. So the surgeon knows he needs to be careful when approaching this lesion. Uh, why are we doing it? Mostly for two reasons. Language lateralization, for example, in a right temporal lobe glioma in a left-handed person. Also for cortex mapping in general, for motor, language, visual cortex areas. And it's important here to think about the alternative. So the alternative for language lateralization is the WADA test, which involves injecting an anesthetic substance into one of your left or right common carotid arteries. And the alternative to cortex mapping is doing it awake during surgery. So none of these look really good or easy. So I think it's nice that we have imaging alternatives to get us through that. There are also pitfalls, as always. It's highly dependent on the field of the scanner. Um, we are just looking at statistical activation maps, so the surgeon needs to be careful. He's not looking at a direct representation of the anatomical structures, and we need the patient to collaborate. At least if we are doing test-based fMRI, I think a lot of these pitfalls will be helped by the development and the implementation of resting state fMRI, which is hopefully coming sooner than later to most of our centers. And at least with some of these problems, it will be a good way of solving it. And we also have a chapter coming up about clinical applications of resting state fMRI, so stay tuned for that. In conclusion, this is a new era for diagnosis of gliomas, so we should think about our job and the questions we can give good answers to and focus on that. We have advanced imaging techniques that give us very important information about the tumor and its microenvironment. We have to stay updated and use those in our favor. And probably all these future techniques will be coming to us sooner than we expect. So we have to take a look literally at what's coming afterwards, after the break, the future of glioma with Professor Marion, so we can make good diagnosis and help our patients. Thank you for your attention.